I would like to introduce our guest speaker. And one of the fun things about being a parent when your kids do competitive things is you get to travel. And so we did Irish step dancing, which took us all over the United States. That's a crazy, crazy, weird thing. But anyway, we were in Philly, and we were in a graveyard looking at these tombstones of the Declaration of Independence signers. And I was blown away because it was, you know, a physician and a lawyer and an author and a patent, you know, winner and a this and a that. And I was like, how do these people do all that? So I'm going to share a little bit about you. You deserve this. So David is, of course, you've met him. Many of you met him before because he's on our advisory council. He's the associate. He has an associate professor of medicine at Harvard Medical School. He's an associate physician in medicine and oncology at the Brigham and Women's Hospital, and associate professor of medicine medical oncology at Dana-Farber Cancer Institute. He received his MD in 1986 and a PhD in 1987 from Yale. After serving as an intern, resident, and chief resident in internal medicine at Yale, he completed training in medical oncology at Dana-Farber Cancer Institute, followed by a postdoctoral fellowship in intracellular signal transduction at Harvard Medical School.
Sure you did.
In 1995, Dr. Frank brought his laboratory group back to the Dana-Farber, where he also maintains a clinical practice. And I think their focus leukemia?
Blood cancers, yeah.
Blood cancers. His awards: Teaching Award, Class of 2002, Harvard Medical School, 1999. Discovery Program Award, 2001. Kittredge Research Award, 2002. Biological and Biomedical Sciences Teaching Award, Harvard Medical School, 2003. The Hoops Prize, Mentor, Harvard University, 2003. Collaborative Physician Practice Award, 2008. Fellow, Molecular Medicine Society, 1999. Fellow, American College of Physicians, 2002. Award for Outstanding Research Achievement, Nature Biotechnology Cafe, 2009. Partners in Excellence Award, Partners Healthcare, 2009. And Team Impact Award, Dana-Farber Cancer Institute, 2009.
How did you do all that?
How do you do all that? I know.
What have you done lately?
So, without further ado, Dr. David.
Thank you, Megan. It's great to be here. So I don't consider myself a guest speaker. I'm an advisory council member, so I'm just here among friends and colleagues. And I am an oncologist at Dana-Farber, and what appealed to me about the healing garden is both just from the humanistic point of view. I think such wonderful things are done here. And then from a very scientific and professional point of view, I think very wonderful things are done here. And what I just wanted to talk about was what I do and how it interrelates with what goes on here. And you heard more about me than even I recalled. You know, and I have some slides and stuff, but I'd rather just be a conversation. I always like hearing from other people anyway, and I get bored when someone just lectures on and on, so I hope that we can just have a conversation together. So I've lived in the Boston area for most of my life, but I was born and raised in Brooklyn, New York. And as you heard, I've been up here for most of this time. And the only reason I mention that is I became interested in being a physician at a relatively young age for a variety of reasons, but one of which was based on a personal experience I had when a loved one who I was with when I was a child collapsed and died right next to me. And you know, this was back in the 70s, and people didn't know about CPR, and we didn't have defibrillators all over the place like we have today. And you know, this was my grandfather, and he died. And I remember, you know, it was obviously very traumatic to me, and I would start reading about what had happened to him, what happens when somebody collapses, what happens when someone has a heart attack. And one of the things I learned, and again, I was pretty young, was there are things that you can actually do to try to resuscitate someone for whom that happens. And I didn't feel guilty myself. I was a kid. I didn't feel that the people around had failed because they were all lay people. No one really knew what to do. But it left me with a very strong feeling that I never wanted to be around somebody who's in medical need and not know what to do. And I just remember that helpless feeling, and I never wanted that to happen again. And that was one of the driving forces for me to become a physician. At the same time, I was interested in math and science. I liked that stuff, and I liked solving problems. And I came up to college, actually the first time I came to the Boston area, I went to MIT, and I started doing research. And I saw this joint career where I could become a physician scientist and take care of patients, which was very meaningful to me, and do research with the hope of trying to come up with better treatments for people. And it didn't take me too long in my combined MD, PhD training at Yale to see that oncology was the perfect profession for me, because I wanted to take care of people who really needed help. And I don't fault other medical specialties who do different things, but for me, I wanted people who really needed care, and it mattered. At the same time, it was abundantly clear that we need better treatments for people with cancer. And so the idea of taking care of people, personally taking care of people, having longitudinal relations with people, and also being able to have a laboratory developing new treatments for people, that to me was the perfect career. And I'm very grateful that I am at a place like Dana-Farber, where really the whole place is set up to foster that back and forth between the laboratory and the patient. And so one of the things that you heard is I am involved in teaching, I am involved in mentorship and education. And the reason I say that is just yesterday we were having our interviews for our medical oncology, hematology fellowship program at Dana-Farber. And I can tell you what we're looking for are brilliant physicians, people who really know medicine. But equally important, we're looking for people who can take care of other human beings. And I've seen this time and time again. You can be the most brilliant person in the world, but if you can't interact with other people, and I'm talking about patients, I'm talking about colleagues, I'm talking about nursing staff, nobody wants to be with you. And actually all of your brilliance kind of goes to waste. At the same time, and I'll be the first one to tell you how important it is to be a compassionate physician. If you don't have the medical knowledge, you're actually not helping people too much either. And I see that quite a bit where people are referred and they say, oh, I love this doctor, this doctor's been taking care of me for 30 years, but I see what the medical care was, and it wasn't quite what it should have been. And so it's great that you love your doctor, but your doctor has to be taking good care of you too. And so if you have one and not the other, to my view, you're not really fulfilling what a physician is supposed to be. So that's really what we're going for. And so, as Meg mentioned, I trained in oncology. I was at Dana-Farber. Initially, if you were an oncologist, you took care of people with all kinds of cancer. Do you want to come up?
Yeah, I just want to cover this down because it's...
Oh, okay. With time at all big cancer centers, there's been a focus on specialization, and I was asked to take care of people with blood cancers, leukemias, lymphomas, myeloma, and so on. So that is now my clinical specialty. And our laboratory studies abnormalities that occur in a cancer cell, and what drives a normal cell to become a malignant cell, and how we can try to reverse that. And there are many ways where these two overlap, and I hope to talk about that. In addition, there are things that we've learned from this that have direct relevance to the types of things going on here. And I really want to come back to that too. So yes, it makes people feel better to have this beautiful setting and the therapies and the classes and the other things that you've heard about. But there's also evidence that it may have truly biological, molecular beneficial effects too. And I don't think we have to, say only one or only the other. It's really the whole thing coming together. And that's why, on a personal level, I think what goes on here at the Healing Garden is so important, and I do try to be as supportive as I can be. So that's kind of the big overview of what I do. And then
We can turn it back on. It was sprinkling lights on your face.
Oh, okay. I could have moved.
It was a good look.
All right. So while that warms up, does anyone have any questions about anything I said in terms of an introduction?
Well, you've kind of alluded to something that doctors 30 years ago were not willing to admit to, which is there's a symbiotic relationship between the Western medicine approach and a healing garden approach. What else have you found to be, what has been the most outstanding finding for you that didn't exist 30 years ago?
Wow. Well, first of all, I would like to come back to this interaction between Western medicine and traditional and Eastern and mind-body,
Okay.
which I'll come back to and
Okay.
I have a slide or two about that. The treatment of cancer patients is completely different from what it was back in the 90s in a very good way. We had chemotherapy back then. So, I'm at the Dana-Farber Cancer Institute, founded by Sidney Farber,
Yeah.
70 years ago, when he started giving chemotherapy to children with leukemia. But, chemotherapy is pretty toxic, and it kills all kinds of cells, and I think many of the people in the room know what I mean.
Yeah.
Now, back then, we had hardly any anti-nausea drugs. And so, chemotherapy can cause severe nausea, and it was awful that we would treat people in the clinic, and I don't think I'm being too graphic for this group, and we would give them a basin and have them go in their car and drive home, and that was awful. That was the standard of care. I don't think we treat anybody any worse than anywhere else. That's what we did back then. So even just better anti-nausea drugs, I think, is a major step forward. We clearly are moving away from that cytotoxic kill everything therapy towards more targeted therapy, something that I'll hopefully talk about. And then this whole idea of activating one's immune system to fight off cancer. That has always had an appeal to people. People want your own body to fight off the cancer, and that's the way that we can do that. And I just want to mention, well, actually, I'll show a couple slides here. Thank you for getting this back going again. So, what we focus on is what happens in a normal cell. And this is really molecular work, and then how a normal cell becomes malignant. And this is what's different between cancer and, say, having a bacterial infection or a viral infection, where our immune system was really derived evolutionarily to fight off infections. That was a big cause of death, it was a big threat to existence, and the ability to fight off a bacteria, a virus, was why the immune system came to be. But bacteria are really very different from our cells. And an antibiotic like penicillin, it affects bacteria, it has almost no effect on any of our cells. That's really fantastic. The problem with cancer, and this is also a psychological issue many cancer patients have, is that it's your own cell that has gone rogue, and it's part of you, or somebody who's not behaving, but it's very close to our normal cells, and to kill that cell and not the healthy cells is tricky. So, the molecular types of studies that we do really talk about what happens in the nucleus of a cell, where all of our DNA is. The DNA is a blueprint for everything that goes on in every cell of the body. But what's interesting is the DNA in every cell in our body is the same, but some cells become liver cells, and some cells become skin cells, and some cells become blood cells. And it's really that programming to say, what part of the blueprint do I need for this cell, and what do I need for the other? And that is what we study, how the DNA in different cells is turned into RNA and protein differently based on what's going on in the cell. And cells respond to things in the environment, and DNA is turned into RNA and protein, and that affects what happens in the cell. And then in a cancer cell, this beautiful pathway with feedback loops gets undermined, it gets subverted. Some mutation occurs which drives pathways that were otherwise present in the cell to cause the cell to live when it should die, to divide when it should stay quiescent, or to remain undifferentiated when it should really become a mature liver cell or kidney cell or skin cell and stop dividing. That's the essence of cancer. And we, you say, how do you go into a laboratory and figure this out? And we have great scientists, and we were talking about collaborating with engineers and physicists to figure out how when a hormone binds to a receptor in a cell, and I'm not going to go through all of this, but this is the type of thing we study, how a protein becomes changed by having phosphate groups put on it, and how those phosphate groups allow the protein to go from the cytoplasm into the nucleus to bind to DNA. This is taking that blueprint and saying, I only need page 33 right now, I'm not going to look at the rest of the pages. and turn on genes that make a cell go from a nice, well-behaving cell to a malignant cell. That's really what we get into. And you might think, oh, we're talking here about writing programs, and autistic programs, and yoga programs, and he's talking about DNA and all this stuff. But to me, as I hope to tell you, it's all one and the same thing. We're human beings, we have all this stuff going on in ourselves, but we come to a place like this because it really matters, and it affects this level too. So we study a particular protein, these proteins called STATs, which regulate DNA. We don't have to get into that. But we really try to understand what goes on in a normal cell and what goes on in a malignant cell and how is that different, and then how can we use that knowledge to develop new types of therapy that weren't available before that might lead to a better efficacy in killing cancer cells and less effect on normal cells. So as an oncologist, I'm always saying, in the end, we can kill cancer cells. We have drugs that can kill cancer cells. The problem is killing the cancer cells and not killing the normal cells. That is the really holy grail in oncology. We want to preserve what's good, what's normal, and just target what is abnormal. And so these are the cancers where these pathways are activated. Many blood cancers, but many cancers affecting other organs. So as Meg mentioned, I take care of people with leukemia and lymphoma and myeloma blood cancers. But the research we're doing in the laboratory at the molecular level affects many other types of cancer as well. And there's a, if you go to a place like Dana-Farber or Mass General or any cancer center, there is a group who takes care of breast cancer, and there's a group who takes care of liver cancer or kidney cancer. But what the field is really going to is saying there should be a group taking care of patients who have this molecular abnormality. And it doesn't matter if the tumor arose in the breast or the liver or the kidney, it's the molecular abnormality that we want to target. And so just to give you an idea of the types of things we actually do, we take cells, we take normal healthy cells, we'll put in this one abnormal protein, and then if you implant these cells under the skin of a mouse, you can see that when we put in this one abnormal protein that we studied, STAT3, we can get a tumor forming, whereas if we don't put that in, these cells do not form a tumor in mice. These mice, I'm not sure how clear the picture is, are special mice in which we can implant human cells and the mouse will not reject them. As part of the genetics of these mice, they don't have hair. So that's why they look, and they're actually called nude mice for this reason, but it's because they don't have an immune system, and that's why we study them. So what we're trying to do in the laboratory, if you really want to get into it, is we're trying to develop inhibitors of STAT proteins. And I'm just going to mention briefly how we're doing that because it's going to swing back to what goes on here in the Healing Garden and what's going on with other forms of medicine and things of that nature. Because one of the themes I want to leave you with is that as a physician, I learn from my patients. I learn a lot of things from my patients. I've learned a lot of things about life and courage and strength from my patients. But I've also learned a lot of medical things from my patients. And in medical school, we often teach the students to listen to what the patient is telling you. That, the medical students often get into all these lab tests and all these high-tech tests. And they taught me in medical school, and we teach people now that if you actually just listen to the patient, you can learn more, by and large, than all of those tests. And it's very easy to say, okay, I want to get this PET scan, this CAT scan, and I'm going to get these 30 blood tests and all that. Okay, they have a place too. But just sit there and let the patient tell you his or her story, and you're 95% of the way there. So, people are always saying, these are all molecular things that you can't see. How do you see them? How do you even measure them? And I'm just going to give you one example. So we measure this protein that affects DNA called STAT3. And so we developed, and we wanted to find drugs that block STAT3. So again, I'm talking about something that you can't see that's in a cell, but we're talking about a drug that you're going to be able to take, and how do you actually connect the two? So here's the system that we devised. We put into a cell a piece of DNA, an artificial DNA, this is recombinant DNA that you may have heard about, that the STAT3 can bind to, and we connected it to a piece of DNA that came from a firefly. And it's the gene from a firefly called luciferase that causes the firefly to glow.
Oh.
And talk about biology.
Glowing.
So when STAT3 gets activated, it binds to this regulatory piece that leads to the RNA and protein for luciferase to be made. And then if we add a little chemical in, the cells give off light. Now the amount of light they give off is less than you can detect with the eye. But it's there. And this goes back to the engineering and physics. If you develop, everyone has their, we all have these phenomenal cameras in our pockets now. If you develop the right type of camera in a dark box, you can easily detect the light coming from cells when this is turned on. And we have a fancy machine called a luminometer, which is just measuring the light coming out of the cell. And if you put in a drug, so we have plastic trays with hundreds of little wells in there with these cells, and we'll add different drugs. I was going to show you pictures. We have a robot that can take drugs from a tray and put it into this tray with the cells, and we can measure in each individual well how much light is coming out.
Wow.
And so a drug that is blocking STAT3 will block the production of the luciferase enzyme from fireflies, and we can detect that, and that's how we can move forward. And this is also why when people say, well, that's really basic research, we don't need to support that because that has nothing to do with people with cancer. Well, the research done on these fireflies floating around is what led to our cancer advances here. And this is one example.
Wow.
That's the NIH stuff.
So,
Yeah. So NIH is so important.
So let me just digress for 1 second. So I keep talking about the interaction between being a physician and a scientist and my taking care of patients and running a laboratory. So a lot of my clinical effort is spent running our inpatient leukemia service, people who come in for treatment for leukemia, which unfortunately, because the drugs are so toxic and kill the normal cells and the healthy cells, people initially treated for leukemia are often in the hospital for 4 to 6 weeks. So I'll spend a few weeks running our leukemia service. And then at the end, at the end of my rotation, I'll say to the patients, okay, tomorrow Dr. So-and-so will be taking over the team for me. And they'll frequently say, well, what are you going to do tomorrow? And I'll say, well, gee, I run this laboratory, and I spend part of my time taking care of patients, part of the time running the laboratory. And it's not uncommon for a patient to say, when I get out of the hospital, would I be able to come and visit your lab? And the answer is, of course. And I think that's the most wonderful thing. So it's not uncommon that I'll say to the people in my lab, Tuesday morning, Mr. So-and-so and his family are going to be coming by the lab. And for the patients and their family members, I think it's very inspiring to see all of these young, bright, hardworking people working away. Now the average layperson doesn't understand exactly what's going on, but believe me, it has an impact seeing the energy in the research laboratory at Dana-Farber like that. And the people in my lab, they know they're working on cancer, but when somebody shows up like that, boy, it focuses their mind on what they're doing and why they're doing it. And I think there's a certain synergy in that.
Yeah.
So I had a patient, and in this case her family, come, and I was talking about targeting this protein, which we hope would be an important advance in cancer therapy. And she said, oh, and when do you think this will actually get into patients? And I said, oh, maybe 4 or 5 years. And I can kind of see her face drop with the thought, oh, that's not going to help me that much. And I can remember that moment so clearly because it really spoke to me, and I thought, we've got to do things faster. We've got to get things from the laboratory to patients faster. And sometimes I think, this is an inside view, you can get really focused in the laboratory on publishing papers. That's how you get people acknowledge success. That's how you get the next grant fund. And then publishing the paper becomes an end in itself as opposed to developing new treatments for people with cancer, which is why we're really there. And so it made me think, how can we actually get things from our laboratory in the Mayer building at Dana-Farber, right across that bridge to the Yawkey building where our patients are as soon as possible. And so here's a goal. Rapid, keyword, rapid introduction of drugs into proof of principle clinical trials. Is this idea even good? Maybe it's not the greatest drug that we can get, but can we test it in people? And the patients who volunteer to be in our research studies are heroes to me. And I hear again and again, well, the reason that the treatments that I got were because people volunteered before, and I'm thankful for this as I'm paying forward. And maybe it will help me, and maybe it won't, but at least I can be trying to help somebody in the future. That to me is, I talked about being inspired by my patients. Again and again, that is incredibly inspiring to me. And so we have looked to get drugs into clinical trials as quickly as possible. And in fact, we have looked at chemicals that have been already tested in people for other things and are known to be safe in patients, but either are used for other purposes or were never developed further. And so we found, using our Firefly system that I showed you a few minutes ago, that a drug, and this is one example, a drug called pyrimethamine, here's the chemical structure, which is FDA approved in the United States to treat malaria and another parasite that can sometimes affect the brain, toxoplasmosis. Exactly. And we found that it is an excellent inhibitor of STAT3. And so this combination sort of jump-started everything. We know pyrimethamine is safe. We know it's FDA approved. You can just go and write a prescription for it. And not only that, we know what levels are achieved in people. So sometimes people will show me, oh, this drug has this effect, but the levels you need to get that effect would be toxic if you gave it to people. But here, this is kind of the way we look at our data, and I'm going to show you very little data, but that STAT3 dependent production of that Firefly enzyme luciferase comes down. Other transcription factors, other of these that read the DNA blueprint, are unaffected. It just targeted STAT3. And this is the concentration, 1 micromolar, 3 micromolar, 5 micromolar. And we already knew that people who take this pyrimethamine for toxoplasmosis or malaria, they have these levels in their drug, these levels in their blood for weeks or months, and they have no side effects. So you talk about jump starting, now we don't have to talk about 3 to 5 years. In 3 to 5 weeks, we could get our approval to get a clinical trial like this going. And so again, we do very basic research. We do long-term research. I'm always telling the people in my lab, it's like investing. You have to have short-term investments, medium-term, long-term. But that short-term, getting things available to patients as soon as possible is so important. And so just as an example, we have a clinical trial now open for one form of leukemia, chronic lymphocytic leukemia, the most common form of leukemia in the United States. Very prevalent. The STAT3 is activated inappropriately in most patients with that disease. And we can tell how we're doing by just drawing blood from patients and looking at the tumor cells and saying, are we blocking STAT3 in the leukemia cells? Are we having a beneficial effect? So it's going from the lab to the clinic, and then those patients' blood samples coming back from the clinic to the lab, and that cycle of having the lab and the clinic working together is what we're trying to do. The last thing I want to talk about this before talking about other forms of medicine and how this all integrates gets back to what we talked about before, the immune response. So there is evidence that when a tumor cell has this activated STAT3, not only is it dividing too much and invading too much, but it also hides from the immune system. Proteins on the cell surface that the immune system can regulate get depressed when STAT3 is activated, and tumor cells tend to make hormones that diminish immune cell function when STAT3 is activated. And so the thought was, well, gee, if we treated these tumor cells with a STAT3 inhibitor like pyrimethamine, how would that affect their interaction with the immune system? And I know you can't read this. These are all these different proteins on the cell that affect the interaction with the immune system. And when we treated with pyrimethamine, the STAT3 inhibitor, we were able to upregulate the proteins that immune cells can home in on and decrease production of the ones that keep the immune system away. And I can just give you one example. So again, how we bring these experiments forward, this was a model of a brain cancer, where we take brain cancer cells and inject it into the brains of mice, and we're able to image right through the mouth. So this is the brain tumor. And when we combine treatment with one of these immune checkpoint inhibitors that are now FDA approved, like nivolumab or pembrolizumab, if you've heard of it, in combination with the STAT3 inhibitor pyrimethamine, we're able to get a dramatic decrease in the growth of these brain tumors. And again, we're trying to get this from the laboratory into patients. So the combination of a STAT3 inhibitor in conjunction with an activator of the immune system is something else we're hopeful about. So again, we're trying to move quickly. One of the things I unfortunately had to spend a lot of time with is writing grants, getting funding. People say, oh, that's a great idea. Well, who's going to pay for it? But these are the ideas that we have that are hopefully underpinning advances going from the lab to the clinic.
Can I add something about that on that slide? Because
Yes, of
from what
course.
I understand, you've got your healthy cell, or your cell, and then the PD-L1 or PD-1 is on it, and hiding the tumor in a way, right? That's what PD-1 or PD-L1, they're like, hey, nothing to see here. And so the immune system can't get at it. So you're trying to get the drugs to knock out the PD-L1 or PD-1 to get at the cell. Is that kind of the basic thing behind it?
Yeah.
Right, the targeted therapy. So you've got drugs that can knock out the PD-L1 and you're treating the environment around the tumor, but what are the behaviors perhaps that people can do, which is where the healing garden comes in and maybe the other places like it, that can help the immune system around that cell, basically. Whether it's nutrition and exercise, Reiki and whatever, all of the pieces that help you help the environment around that cell. Because isn't that the kind of immunotherapy idea, is that the environment around the cell, that's what you're looking at now instead, in addition to the cell itself?
Yes. So first of all, you explained the whole immune effect better than I did. So thank you.
I've heard it a few times.
You provided a great segue to what I want to talk about next.
Right.
So thank you. And I want to start with this, because now I'm really going to talk about other aspects, things I've learned from patients and things that are directly related to what's going on here. I just want to give a few concrete examples. And this is a case report of a patient of mine. I keep saying I've learned from my patients. So this is a very clear example. And this was a man who, was a number of years ago, who had generalized fatigue, didn't feel well, nothing really focal, and was found to have a very elevated white blood cell count of 39,000. It should not be higher than 10,000. Very elevated. And then he was diagnosed with chronic lymphocytic leukemia. So this was a man who lived in New York at the time. So this was in New York. And then his white blood cells. So we often will just, back then we didn't really have good therapies for this. We often just observed that the white blood cell count got even higher, 60,000. Again, it shouldn't be higher than 10,000. And here's what the interesting part. So he was offered chemotherapy at a prominent cancer center in Manhattan. But he consulted with a practitioner of traditional Chinese medicine in Chinatown in New York. And the quote from him was he was given this mixture of twigs, roots, and bark. He was told to boil it in water, allow it to cool, and concentrate through evaporation, and strain it, and then drink it. Okay, so these are, I don't know how well you can see the numbers, but it's not that important. You can see the shape of the curve. So these are his white blood cell counts. This is the total white blood cell count. These are the lymphocytes, the actual malignant cells. So, going up, 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 and these were all blood counts taken at very prominent medical centers. We had all the data. Began the herbal extract where that arrow is, and again, you don't have to read the numbers, you can see what happened.
What was the period of time, I couldn't see on the bottom, for them to drop that fast?
Yeah, so this is in 91, this is going in 92, 93, 94.
He
So
maintained
it
it
fell,
for years.
Yeah. And then, so this was in New York, and he relocated to Boston. I became his oncologist. And I collaborated with people at his cancer center to get all this information. So I said, hey, can you bring in a sample? I did nothing for him medically. I wasn't going to touch this. This guy was doing great. I said, but can you bring, and he was taking it, as Meg was asking about the maintenance, he was drinking it every day still. I said, can you bring in a sample of this for me? So, he said, well, you can give me some containers. So I got him, a urine cup. I said, here, go. He came back, with his container, and, the clinic assistant said, oh, should I run a urinalysis on that? I said, yeah, that's okay. And so we took leukemia cells, and this was his herbal extract, and we diluted it, and we showed that the herbal extract could kill the leukemia cells, and what was the control being? Science was have to control, so we took some black tea and some green tea, and I know there's probably medicinal substances in black tea and green tea, but there was not much of an effect there at the same dilutions, but that this herbal extract that he brought to me had this beneficial effect. And one of the things I think is very important about, when you talk about traditional Chinese medicine and so on, there are plenty of physicians who can just roll their eyes on this, or hearing these stories and roll their eyes. So, there's just an anecdote, or who, is that verified? So I think it's really important to actually publish in the medical literature. So here is this case report that we published. It was published in 2003. Where we presented the clinical data and I showed you one of the figures about the laboratory effects. We did some other molecular studies to show this, to try to get it out of the realm of some anecdote from some patient, who knows what they're talking about, to make that hard in the literature what doctors and scientists are used to reading. And I think it's really important to bring the two together. So I really want to make it clear, I didn't start out by saying, I want to find out about herbal extracts in traditional Chinese medicine. This was a patient who came to me, and his story was presented to me. And I could easily have said, oh, that's very nice, but here, here's your next appointment, here's your next blood test. But I, listened to what he told me, and we moved forward from there. And I don't want to go through too much detail, but based on that, so, we've published many papers over the years. That paper still gets me people writing to me today about that herbal extract. And I'll come back to that in a second. So from that, people said, oh, the a Magnolia extract has medicinal activity, and we purified this compound called hinokiol, which comes out from magnolia trees, and we showed its molecular effects. So, again, there are all kinds of reports in the literature about the medical benefit of magnolia extracts, but again, we wanted to make it something that a doctor or a scientist could relate to, and so this is not just some random story or something from the literature of people, indigenous people from other parts of the world, or hundreds or thousands of years ago. We wanted to make it real to people right now. I'll just give you one other example. So, again, based on this, marine organisms are a very rich source of biodiversity and traditional medical therapy. This is, again, this picture is not that clear. This is a marine organism called a bryozoan, and it makes this very complicated molecule that actually a good organic chemist would have to spend years to make. This thing can make so beautifully. And again, we showed that it does have effects on a molecular level, and we take it down to that molecular level to make it clear that not only is there evidence it can have anti-cancer properties based on Polynesian traditional medicine, but based on rigorous laboratory studies as well. And so it's hard working with herbal medicine and natural products. So people often said, can I get this herbal extract that this man for whom we published that case report had taken? And I actually got in touch with his herbal practitioner in Chinatown. And he said to me, well, I would vary the mixture based on the pulse and based on other things. So it was not always exactly the same. And then when I heard that his blood tests were getting better, I varied it again, and so on. So it makes it hard to be, because I want to get what he got, and I would say that too. But it was hard to figure out exactly what he got. And so the mixture of compounds, and that these mixtures may actually be important for the activity, and maybe it's not only the one compound, maybe it really is the combination. It's a challenge. But we have, I talked about that people have, low risk and high risk projects. A lot of people in my lab, in addition to their experiments directly on STAT3, are looking at herbal mixtures that we've gotten from China, that we've gotten from India, that we've gotten from Native American groups as well. And we're trying to be open-minded and see what we can learn about it, but it's tricky.
Is it any more tricky than the other things that are already FDA approved?
There, at least we're starting with a pure compound that everyone can agree on. Because these mixtures and they vary with different people, that makes it challenging.
Yeah.
But that might be the key to why they're active. So we
That's
can't
right.
ignore that either.
That's right.
And so that's what we're working on.
Okay.
And so the last thing I want to talk about gets back to the whole body and the environment. the environment of the human being, which is so important. And again, which is why, one of the reasons why I feel very connected to the Healing Garden and what goes on here, the beautiful and wonderful work you do. So, I was invited to give a talk in Beijing last year. Some of this was translated. I cannot promise that the translation is accurate. But, we wanted to figure out if you use something like acupuncture, traditional Chinese medicine, or things like diet or exercise or other person-to-person interventions, can you actually measure in a human being what you did? And again, if you can't, maybe it's because we don't have the right ways to measure it, and that doesn't negate anything either. But again, I thought if we can rigorously show on a scientific level in the way scientists and doctors can relate, what happens when you use acupuncture? What happens when you use Reiki? What happens when you use music therapy? Are there measurable things that you can do? And I just want to show you an example or two of that. So here is one concrete example that we did with colleagues at the Dana-Farber Cancer Institute, and we focused on a very defined problem, chemotherapy-induced peripheral neuropathy. And so a neuropathy, of course, is damage to nerves, and it can cause things like burning, tingling, numbness, pain. Often involves the longest nerves in the body going from the spinal cord out to the fingertips and to the feet and toes. And I would say that people who haven't experienced it, think, oh, well, so it's a big deal, you get a little numbness in your fingers. But, again, I am thankful it has not happened to me, but I've taken care of hundreds of patients for whom it is really life-altering and very disturbing, and you can't button your shirt, and you can't turn a key, you have constant discomfort in your fingertips. It is not pleasant at all. And so, unfortunately, many of the current drugs that we use cause this, and it goes back to the non-specific nature of chemotherapy. So many people here have heard of drugs like Taxol, cisplatin, carboplatin, vincristine, vinblastine. There are whole classes of drugs that do this. And so we focus on patients with breast cancer. We frequently get drugs like Taxol or Taxotere that can cause this. And it happens commonly and quickly. Unfortunately, we often have to reduce the dose of chemotherapy because of it. And we're all, so we're trying to give as much chemotherapy as we can to kill the cancer cell, but we don't want to cause irreversible harm to people. And neuropathy can last for a long time, and sometimes it never gets better. And what we do now, well, so here's a list of things that we do for people with neuropathy. I think I can say in general, when you see long lists of things that we do for people, it means that we don't have anything good. Yeah. And that's why there are dozens of different things that we try. And some help some people, some help others. Most don't help that much. And so, again, at Dana-Farber with the Sachem Center, they're really trying to be open about, are there other ways to treat people other than all those drugs I just mentioned, and really being respectful of the fact that people around the world have had cancer for thousands of years, and there is literature on a lot of different things people have done, and can we be open-minded about learning from that? And as many people here, of course, are aware, acupuncture has been put forward as a way to treat many conditions and many symptoms. And so the hypothesis, again, being very scientifically rigorous, was can acupuncture improve the symptoms of this chemotherapy-induced neuropathy? And we focused to keep the groups as homogeneous as possible, women with breast cancer. But the idea being that perhaps any finding could translate to other people. And so it was a combination of one of my breast cancer colleagues who also heads our Sachem Center, Jennifer Ligabell, and a practitioner of acupuncture who's also a colleague at Dana-Farber, Wei-Dong Liu. And so this is the design of the clinical trial that we assessed patients to make sure that they had the condition. We asked them to sign a consent form. Again, when you're talking about clinical trials, we always try to be very clear about risks and potential benefits of participation. And then patients were randomized to just get usual care, which could involve any of those vitamins and other things, or usual care plus 18 acupuncture sessions. So it's a real randomized trial. It's not blinded. People know if they're getting acupuncture or not. But it's the way if we were testing a new drug, this is kind of the design. I just really want to stress that just because it's acupuncture doesn't mean we shouldn't be as rigorous and approach things the same way. And so the main outcome, because neuropathy, it's hard to measure. Now, I said before that listen to the patient. You know, that's what we teach medicine. It's like the patient's going to tell you 95% of things. In fact, in reality, when it comes to measuring neuropathy, the patient tells you 100% of things. We don't really have a good diagnostic test for neuropathy. The test is asking very structured questions to the patient about the level of pain, functional ability to. And so, you know, with medicine, we have everything's abbreviated. We have the PNQ, which is the Patient Neurotoxicity Questionnaire, where there are defined questions on numbness, pain, burning, tingling, and all of this, and it's a scale of 1 to 5, and we quantitate it. But it all comes from the patient. It's not from any CAT scan or PET scan or a fancy blood test. It's from what the patient is telling us. And so here, now I'm going to bring this back to what we were saying before. Where do I come into this? So I showed you our system that we developed, that we can measure light output from cells, and we used it to find drugs to block STAT3. So with a few variations, here's what we did with that same idea. We took cells like this that were producing this luciferase enzyme, and rather than adding drugs, we took serum samples from the patients before treatment and at discrete points on treatment. At 4 weeks, 8 weeks, 12 weeks, and so on. For the patients getting the acupuncture, for the patients not getting the acupuncture. And we were looking in their serum for circulating molecules that would affect these key pathways. Pathways like STAT3, pathways like inflammatory pathways, interferon-related pathways. So things that you can measure, but coming from the blood of the patients on these interventions. So it's the same, it's just, you know, trying to be flexible with how we think about things. We have this system for drug development. How else can we use it? How else can we modify it to help people who, in this case, are getting acupuncture? And so the other thing about this system is we were not only testing one hormone. Interleukin-1 alpha may be important, so you can measure that. But there might be 10 other ways that you could affect this pathway. Maybe a cytokine, a hormone like interleukin-1 alpha is going up or down. Maybe another cytokine, maybe one that we haven't even identified yet is changing. Maybe there are proteins that can block the effect of interleukin-1 alpha. But the system we had was agnostic to what the defined mechanism was. We were just looking at these inflammatory pathways, these interferon pathways, these acute phase pathways, and whether they were being changed in the serum of patients or not. So it's getting back to this environment of the human being, and how something like acupuncture, which at the one level you might think, what does that have to do with these hormones in the serum? It actually potentially has a lot. And I'm not going to go through all the detail, but this is kind of how the data come out, because I really want to be clear. We were rigorous about this. We were blinded. We got the samples. Everything was in duplicate. We looked at these various pathways. Here's the patient ID by number. You know, of course, everything is anonymized. This is called a heat map. The red are high levels, the blue are low levels. How does this change over time? And we were able to detect in one, that the patients who had the worst neuropathy tended to have higher activation of these pathways. There was some general effect from acupuncture in everybody, but the patients who benefited the most based on that questionnaire I told you about, the ones who had the biggest increase, had the biggest change in some of these markers in the blood. So the idea isn't to refute or affirm acupuncture. The idea is to learn what it's doing, learn who the patients are who benefit most, learn what other combinations, acupuncture and what else, for example, might be beneficial. And so this is kind of how we have proceeded. And now we have tried to expand it beyond acupuncture, which is one example. Dietary interventions, which we were talking about. You know, I think everyone understands what you eat has a big effect on our internal environment. Exercise. There's, and I mean exercise including aerobic exercise walking in the garden. I think it's clear that exercise is beneficial for people in preventing the development of cancer and improving outcomes after the diagnosis of cancer. And what can we measure from that? So we're just beginning to do that. And then, I'm sorry, I'm using this word, neuropsychological interventions, but what this means are things like Reiki and massage and music and yoga. And again, I think we should be rigorous about it. I'm not trying to group all these together. I'm saying individually, I think there's clear evidence that they can alter these hormonal, environmental effects in our body. Please.
So going back to the heat chart that you showed there, was there a consistent correlation between the acupuncture patients, or was there a big gradation among the acupuncture patients, so that some people maybe got a really strong effect and other people really maybe none?
Yes, there was a lot of variability. And in fact, the numbers in this study were relatively small, and we felt statistically, again, we had biostatisticians involved, that to have more statistical power, we actually needed to expand to a bigger cohort, which is what we're doing. That's why I haven't told you hard conclusions, because we're still accumulating data. And I think we know that, and the acupuncture practitioners will tell you, some people seem to do well, and some people seem to have no effect on it, and they have that comment, but we're trying to parse out who is it who's doing better or not. For example, some people in the beginning had very high levels of this activation of NF-kappa B, this inflammatory pathway. And in some people it seemed to go down and they seemed to benefit. In some people it didn't go down at all, and they generally did not benefit. But why that is, we don't know yet. So like in all science, the more experiments you do, the more hypotheses, the more ideas you have to test. But that's okay, that's how things move forward. So I didn't mean to gloss over, we don't have hard evidence yet, but there are a lot of very suggestive findings on it. And we're now trying to expand that, as I mentioned to other, we started with acupuncture because we wanted to give one focused example, but I think all of the things that we talked about, all the things that people introduce themselves as being interested in or participating in, undoubtedly affect things. How much, which people are more likely to benefit? Is it possible that someday you'll come in, get that blood test and say, oh, you're the type of person who'll do well with Reiki, and acupuncture maybe not so much? Again, that's a few steps down the road, but that, I think we can really bridge the molecular and the things that we already know make people feel well and feel positive, that we can bring it all together. They're not in conflict. I guess that's my main message. It's not one or the other, it's all together.
Can I ask sort of a follow-up to
Of
this?
course.
So if you were to go back to all of those patients that did the acupuncture, the ones who were not getting any effect, do you think they would have said, I'm not getting any effect? In going back and listening to the patient in terms of whether or not something is good, is helping them?
So there is a correlation with that questionnaire, that they were not having benefit. And here's again another level of complexity. A lot of people said, my neuropathy wasn't that much better, but somehow I just felt better in general.
Yeah.
And that is not to be dismissed either. Yes, the goal was to improve the neuropathy. I'm not trying to change the goal.
Right.
But if somebody tells me, I do that and I clearly feel better, I'm sorry, I keep persevering on this. You got to listen to the patient. If that's what he or she is telling you, you have to believe that.
Well, the other part of it is that there's no harm, there's potential benefit, but not the harm of, killing cells that are healthy. So if you have a dietary intervention that may or may not help in certain ways, or exercise interventions, they're going to be positive in some way.
So when I was a medical student, I remember going to see a patient with a senior doctor, and I didn't know anything, and the patient had another non-cancer condition, was saying how she takes vitamin B6 and she feels much better, and the doctor said, the vitamin B6 has nothing to do with that, it's a complete waste and so on. And even though I was a medical student and knew nothing, I thought, what did you tell her that for? You're telling me that she feels better when she takes the vitamin B6.
Yeah.
What's the point?
Yeah.
So you're talking about no harm.
Right, as long as it doesn't do harm.
Okay, so I remember this also. This was a patient who had osteoarthritis and he was very painful, and he saw an ad at 3 in the morning on TV for magnets for the osteoarthritis, and he wanted to know my opinion on it. And we're talking about it. I was saying, there's not clear evidence, but it's possible that magnetic fields can affect things like that. And then he told me that it was $800 for the magnets, and I knew this man was not of means.
Yeah.
And so that changed the conversation slightly for me. I'm thinking, well, on the one hand, I feel, I'm not going to cause harm. On the other hand, well, maybe there's financial toxicity.
Yeah.
And how do I say this appropriately to this person without taking away his hope? And I don't want him, he's an elderly man on fixed income, I felt $800, boy, that's a lot. And trying to find that right place. Because we want to take care of all of the person, which is very important. I won't go through all this. These are, how we're trying to further this. I think the message, the last thing I do want to show is, I didn't do any of that stuff alone. And it is science is a team sport. I've had wonderful, wonderful people who are so dedicated to this, who want to help people. We've had funding agencies, the government, most of all, the many, many private foundations, individuals we're so grateful for. But to me, people say to me, what would you do if you weren't an oncologist? I can't ever come up with an answer to that because I love what I do so much. It's kind of hard to think what would be next. I love taking care of people. I want to help people. I wish at times we had better things to help people. Then I go to the other side of what I do, and we're trying to develop new things to help people. And it's all part of the same thing. We're all human beings. We all have to help each other in whatever way that we can. And I just want to conclude by being back where we started here at the Healing Garden. I think it is absolutely clear that whatever your role here as a volunteer, as a client, as an employee, that we're just trying to help each other in whatever way. And it's not to say this is good and that's bad. It's whatever helps each other we really have to foster. And I thank Meg and everything going on here, and I'm happy to be part of it. Because I think in life in general, that this is what we have to do. So I'm happy to answer any questions, but this is kind of an overview of what I do, and I appreciate your attention.
Thank you.
I want to respond to the luciferase enzyme because to me it illuminated, unintended, but it illuminated on a different level for me that we all have our own light, and whatever we do that is treatment, integrated therapies that makes us feel more alive and helps our own light to shine, and that's really good. So that even on the firefly level, it just really touched me. That's what that was doing.
I completely agree with that. That is beautiful, and I completely agree with that.
I wonder if you take into account trauma, and this is some of the work that I do, that if somebody has experiences in their lifetime that they haven't been able to fully integrate, how that can affect their health and in freeing them from those experiences and helping them to open. I just wonder whether you take that into account too, or have looked at that in any of your research.
We haven't in the research, but as a physician, I can tell you I think that's enormously important. And it's hard. It's hard, people who've had trauma in their life, whether in childhood or as an adult, trying to get through that. I think it can have very negative effects. I'm sure that it can measurably affect some of those pathways that we talked about. And we know that chronic exposure to stress changes in the connections in neurons. I think these are all important. And again, being a human being is so complex. Even people, we think we know people who know people so long. Sometimes you realize you don't know anything about that person. And I think trying to be as supportive in so many ways as possible is really critical. Whether we can measure it through these molecular things or just knowing whether another human being is experiencing, I think it's equally important.
I'm just curious whether the same research applies to cancers caused by genetic mutations. Is the research similar, or is there research?
Absolutely. So we know even common mutations like BRCA mutations, and there are so many. The molecular changes they induce in the cancer cell go through these same pathways. So there may be a slightly different origin, but in the end they funnel through these same pathways and they can be equally effective. We know that people who have certain genetic syndromes are at continued risk for cancer, even if they've had one, there may be others. And one of the things we're interested in these compounds that are clearly safe and they can take indefinitely is whether they can also prevent cancers from developing, particularly in people who are at higher risk or a higher lifetime risk. Prevention is much harder because you have to prove safety over a long period of time. You're taking somebody who's visibly healthy and giving them something, and so it's a much higher bar to make sure that it's safe. But we're very interested in that. We're doing a lot in mouse models of genetic risk for cancer, but I think that's one way we can try to lower the incidence even in people who are at higher risk because of their genetics.
What about autoimmune disease? Do you find that people who have autoimmune disease are more apt to develop cancer over a long period of time? Like psoriatic arthritis, something like that?
Yeah, that is a very interesting question. Because it's both the condition itself and actually some of the treatments now that we have for these conditions which alter the immune system and alter the immune response.
Yeah.
And we're still trying to sort through that. I'll tell you that, we've published about our work in targeting cancer cells by targeting these pathways. I've been approached by a lot of biotech companies interested in autoimmune diseases for ways to use these approaches to try to specifically treat those. And the immune system, it's a tricky thing. I remember somebody saying to me, we should all once a year, like you're doing your car in for a tune-up, you should get a tune-up of our immune system. I think he really meant like a boost. But the immune system, like everything else in the body, is at just the right level. If it's too low, we know we're at risk for infections. If it's too high, we get these autoimmune conditions, which can be extremely debilitating. And keeping that balance just right is tricky, and that's what we try to do. I think there's clearly a relationship between that and cancer, and we're still trying to parse out all of those.
I don't know how to word this without sounding judgmental, and it's not towards you, but how much do you think it could be attributed to the fact that the patient is starting to care for themselves rather than surrendering themselves to the medical community? And that's all I guess I'm going to say. I just observe some people who have been victims, and
Treatment's not always.
they just give up and they go. If they can't go to the doctor for it, it's a disaster. Whereas other people are taking accountability and they're doing whatever they can do on their own. I mean, they'll use medical care, but I mean, a lot of these things are sort of interactive, right? You're in acupuncture, you've got to go and and you've got to make a commitment to that. I know in your case it's a study where there was randomized, so maybe you take that part out of it. But I do think there's a difference in the way people react, the way people approach these things that I think matters. That's my personal.
No, I agree with you. I think that it's very important. And I've had people say, I present to them what I think the treatment should be, and they say, I'd rather not do that, or I'd rather take care of myself, or I'd rather. Sometimes people say, I want you to give me this therapy, which I think is harmful, which can often be a very difficult situation. But I think that personal engagement and involvement are very important. And occasionally, I've had patients who had highly curable malignancies, and I say, this is the treatment we recommend, and they say, I'd rather not have that. I'd rather do my own thing. And I believe very strongly in individual autonomy, and I don't think that physicians or anybody else should be paternalistic and say, no, you have to do this. On the other hand, I hate to see somebody do something that's really harmful to themselves and not try to dissuade them, and it's important to try to find that right place. But I agree, the individual human being and how they engage with themselves, their community, their self-help, those are all critically important.
When you're talking to a patient about a treatment plan or potentially participating in a clinical trial, as a patient, it's often hard to know what questions one should be asking. So assuming you're talking to somebody who's not a scientist, but wants to sort of set expectations in the right place and make the best decisions, what do you think are the most relevant questions somebody should be asking you in that case?
Yeah, it's hard. I think as a physician, you have to engage with each person differently. The idea that it's a cookie-cutter approach, that's bad. And you have to figure out what each person wants or needs. And some people come in with a long list of questions or their internet printouts, and some people say, I don't have any questions. And you have to find that right place. And certainly there are some people who come in and say, people who are coming from another country where the parent is the patient who doesn't speak English, and the child says, they don't want to know anything, I'll take care of everything. And you're never quite sure. So to me, it's important for the patient to understand choices that are being made. When I first started out in medicine, the doctor told the patient what he or she should do. That wasn't good. The pendulum went so far the other way where the doctor didn't, because you don't want to be paternalistic, you just present the options and let them choose. that I felt put an undue weight on people. Like, how am I supposed to know, which of these options is better? Or the question of what would you do if it were you? And I will tell them, I'll say, look, this is the way I would look at it for me, but I'm not saying that it's right for you or someone. I would weigh this and this. I say, I don't, that toxicity is too much for what I would take. Or I would, even though there's only a 5% chance of it working, I would do that. So if the patients have questions, great. If not, I will try to suggest to the patients what the questions are. And if somebody says, I have no questions at all, that concerns me. I don't want to railroad anybody, I don't want, but it's getting that right balance between what a patient wants to do, what I think is best, and finding the right thing for that individual person. But, I remember years ago we had this thing about cultural competency, understanding different people's culture and everything. So I thought, they're going to teach us about different cultures. What they taught in those training sessions were figure out what the person in front of you wants and needs and interact with them like a human being, like everybody else. It doesn't matter if they come from this country or that country, or old or young or educated or uneducated or wealthy or not wealthy. Just figure out what that person needs and interact with them as an individual person. And I say that all the time. So, I take care of patients with leukemia. That first conversation when you explain to them what they have, excuse me, what the treatment is, I've done that 1,000 times. But every time I walk in the room, I focus, I think, I've done it 1,000 times, but this is the first time for this person, and it's really important. And I teach at Harvard Medical School. I often teach first-year students in the first few weeks of their classes, and I'm always saying to them, first impression is important. I can't tell you how many times patients have said to me, I remember exactly what the doctor said to me that first minute. I said, don't blow it. Think about this person in front of you. It doesn't matter if you're running around from here or there, having stress. When you're in that room, the only thing on your mind should be this human being in front of you and how you're going to interact with them. And that hasn't changed throughout my career, and I certainly hope it doesn't change.
Well, it would be gratifying if a lot more health professionals in the Western style had that attitude, right? Because we often run up against to the point where I remember 20 years ago when Beth Israel started their Center for Complementary Therapy. And there was a lot of pushback by the complementary therapy people because they were feeling that they were being held to the Western medicine standard, right? And they had to be evaluated, and if you didn't have a positive clinical outcome, then it was not worthwhile for people to pay attention to this stuff. I think our attitude has changed, and thanks to folks like you and the teaching and whatnot that you're doing, I think the health professionals are a lot more open-minded than they were. I think there's still a long way to go, but I think that people are being given more fair opportunities to think about what's best for them. And I think there's a collaboration and a complementarity of the different ways of approaching things. But I think it's the person-on-person piece that really matters. And as long as physicians in particular are getting that message, I think we'll be better.
I can tell you one thing, on the other side of the ledger, you may read about physicians' burnout and how in medicine, people are getting burned out. And I talk about all this interpersonal stuff. The one thing that makes that difficult is when they say, oh, you have your 20 patients in clinic this morning. And sometimes you're talking to that patient and you realize you need to spend another 15, 20 minutes talking to them. And you know that you picture in your mind the list of people who are sitting on that waiting room who are waiting, and the bean count is saying, well, you have to keep the rooms moving and everything. That to me is the worst thing. Because you can't make up for the time you need for the patient. And sometimes like the residents will say, okay, we'll make a quick visit in for this patient, but they won't realize it. I said, they know all the time. When you're trying to get out, they may be too polite to say anything. Don't think that they don't realize that you're trying to get out of that room. And it's the time that's so important to feel that you're not rushed, that you can sit there and spend whatever time that person needs. That's really important. And some of our structures are working against that, and that is not helpful.
But we follow the money, right? If you follow the money, then you're going to have those kinds of conflicts, and you'll have to get to a place where that was the point of that.
I have a question about the inflammatory pathway, because you mentioned it, and there's lots of discussion around how to reduce inflammation. How does that work with prevention in the first place? For people who've never had cancer, or for those of us who have? to reduce risk of recurrence? Is the because it feels like the inflammatory pathway, maybe we could affect it in some way by our behavior. I don't know for sure, but can you speak to that, both in prevention and recurrence risk?
Yeah, so I think there's good evidence that inflammation in general can promote cancer. There are certainly environmental and neurohumoral factors, the hormones that we make when we stress, epinephrine, adrenaline, things like that, that can lead to inflammation as well, which can promote cancer to a certain extent. It's not all or none. Certainly these mutations, these genetic events, but they can drive cells to proliferate, to grow, to replicate their DNA when it's more likely a mutation will occur. And how else do we know this? Well, pharmacologically, we know that people who take anti-inflammatory drugs often have a lower risk of cancer. Many types of cancer, like aspirin, for example. But the problem, I keep talking about these balances. So aspirin does decrease inflammation, it blocks this NF-kappa B pathway. Aspirin came from this willow bark from hundreds of years ago, but it blocks one of these transcription factors. But aspirin also increases your risk for bleeding because it decreases the function of our platelets. And so like everything else, if it weren't for that, I'd say, oh, everyone should be taking a lot of aspirin. But the risk benefit is pretty narrow because people who take aspirin, especially high dose, are at increased risk for bleeding, especially in the GI tract. So inflammation probably does promote the onset of cancer. It may cause increased cancer recurrence, potentially. Yeah, evidence is mixed. But that, I don't want anyone to jump and say, okay, then I need to take a whole bunch of anti-inflammatories because that can lead to a host of problems that may be worse. So I think inflammation, these pathways do drive malignant cells or pre-malignant cells, and we're trying to figure out ways to target them. But the answer, at least right now in 2018, is not just jumping ahead and saying, I'm going to take a ton of aspirin or ibuprofen or so on. So we're trying to find that.
Might it be taking a ton of exercise or walks in the woods?
Or vegetables or
Or
fruits.
or vegetables or whatever.
So there isn't phenomenal scientific evidence for that yet. My personal feeling is the answer is probably yes. Because there is good, so exercise while you're doing it causes an increase in inflammation, but afterwards leads to a profound decrease that stays for a long time. Antioxidant foods probably they can really repress inflammatory pathways as well. But because people are so complicated and diets are so complicated, the studies are not overwhelming. I think on an individual level, the answer is probably yes. Things like exercise and meditation and yoga and cruciferous vegetables and other things like that will have benefit by targeting these pathways. I'm sorry, Meg, I know I went a little over.
No, thank
apologize.
you. Awesome.
I just want to send a blessing to your grandfather for getting you started in where you are today. So.
Yeah, thank you for saying that. At the time it was incredibly traumatic, but I often think back at that moment as hopefully that I've helped other people based on that. And thank you very much for saying that.
Yeah.